this month is very significant to the health sector. First of all, the International Day of Nurses is coming up. That will be on Sunday, the 12th of May. And also May marks the Maternal Mental Health Awareness Month. And these are conversations that will be going on throughout the month, among others. And the reason why I'm bringing this up is because we need to set pace for a discussion today. We're talking about maternal, neonatal, and child health. Now, this is very crucial for us as a country because for a long time we've been grappling with maternal, neonatal, and child deaths, and these deaths have actually drastically gone down with time, and we shall be looking at those numbers later on. But before we get to that, let me introduce my studio audience, or rather panel, who are here to help me have this amazing conversation and very crucial at this point in time. We have Eunice Ngari, who is a midwife and an official at the Kenya National Union of Nurses. Thank you for making time. And of course, George Oele, who is the AMREF Community Health Strategy Technical Advisor, and he is in touch with the community health workers across the country. Thank you for your time. We shall be expecting Jane Wanyama, who is also the CEO of the Aga Khan Hospital from Kisumu, and she's also a career nurse midwife, and now also is into maternal and neonatal nursing, and she'll be coming to give us more perspective, especially from that side of the country, and to be specific, Kisii County. But even as we wait on her, now, Eunice, the numbers look good so far. We seem to have brought down the numbers of deaths in as far as maternal, neonatal, and child deaths are concerned. Yes, but I'd like us to use the story of Evelyn Namukula. You remember the lady who had her quintuplets in Kakamega County, and they had to be moved to the Moi Teaching and Referral Hospital because they had complications, and unfortunately we lost her. And with that, we also lost two of her children that were boys. I think her own story is a great case study to actually take stock of where we are in as far as maternal, neonatal, and child health is concerned. Now, to start with her, as a mother, she was doing well. The country was celebrating her. She was being given the morale to keep going and take care of these 5 children. But at some point, we lost her. And the doctors said that she actually suffered from... she said she had chest pains, and then heart condition. And this is just one of the many examples of some of the complications that come up after giving birth. What are some others that you've come across as a midwife?
Okay, thank you, Gladys. And first of all, I want to celebrate all the nurses in this country. It's a great honor to have me here and my colleague and whoever else is coming. Thank you. What I want to say is that complications are there, and they are many. I would like to categorize them in terms of, recognizing them before the mother gives birth. And then another category is during birth, and then after birth. The ones we want to categorize before can be identified. I would say 60% of the cases, conditions that mother has can be prevented. Actually, they are preventable. But the question is, and that's what we need to relook now, is what is the alert sign? What is this sign which can tell the mother now, this is a danger sign? We have many conditions like, bleeding, a cord comes out, you call it cord prolapse. That is before. And those are the emergencies we have within the hospitals. Then during birth, there is postpartum hemorrhage after the child is born. Yes. You have postpartum hemorrhage. You have other underlying conditions like heart conditions, which should have been identified before, during the antenatal clinic. Okay. But now we don't have a profile of where she has been attending the antenatal clinic, so that now that heart condition could have been, handled. Because around there's also other conditions, pneumonias and other, critical conditions that may have around there, so which was not identified. It's so unfortunate, but
yeah. So in her case, they said she died of a pulmonary embolism, where a blood clot blocked blood vessels into her lungs. Now, is that somewhat related to the hemorrhaging that you were talking about after birth? Because it said she also bled a lot after birth. And is this something that you can actually foresee before birth? Is that what you're saying?
I am saying, and I've said, 60% of those emergencies are preventable.
Okay.
The only problem I have, I work in ICU, so it's that alert sign. What is this sign which she had, which somebody would have said, oh, let's look, this would have been this and this. Okay, we focused on her delivery and 5 children, which was good. And even after delivery, it was, 5 children is not easy for a mother. She may have bled a lot. A clot may have ran through the, the system and all that. But at that point where now this is pulmonary embolism,
Yeah.
that is very critical. That is an emergency. And that's what I'm saying. It would have been prevented if somebody would have thought of that, the condition around there. But you see, no one thought about it. And that's why it's so unfortunate. I'm not talking of, negligence, but there's a bit of, we should know a bit of history.
So more groundwork should have been done.
Yes, should have been done, so that now we see this mother is liable to get maybe such a condition. But many other mothers get those conditions, but is unfortunate if we don't have a good alert sign of what is happening to this mother.
Okay, now George, just listening to this scenario of Evelyn Namakula, how she was able to get to hospital. Many other mothers do not make to hospital, and they never make it to the headlines, so we never know what they succumb to. But community health workers are the ones who go door to door, and they see a lot of these cases. What are some of those causes you've been told that are continuously being noted as the causes of maternal death?
Thank you, Gladys. First, we are very sorry for what happened to this mother who was highly celebrated. And as she's trying to bring it out, most of the conditions affect the mothers could be detected at the community level. And that is where the community health workers have a critical role in visiting households and providing health care and identifying the danger signs. Some of the danger signs that could be identified early enough when a mother is pregnant or even before pregnancy. That is a mother who is not yet pregnant and is in the reproductive age. The community health workers who are trained to educate these mothers would identify a mother at risk. Maybe the height of this mother may compromise her life in pregnancy and at the point of delivery. And therefore, they follow up these mothers who have these kinds of challenges in health or risks and monitor them, work with them from the household to the facilities through a referral mechanism, identifying what could cause risk during pregnancy and what could cause risk during delivery. And therefore, such mothers, when identified, must be supported to deliver at the health facility. This, the community health workers have been doing so well. And where this has happened, there is significant increase in the survival rate of the mothers and the children or neonates that are born in the hands of the skilled mothers.
Okay. Now, Eunice, the reason why I brought up the importance of community health workers, West Pokot County is one of those counties in the country whose statistics of maternal death paints a very grim picture, and the county attributes the deaths of mothers and children to delay in reaching hospitals and not attending antenatal care. So, in this case, if there's somebody who is walking with them till the last stage, the possibility some of those things you were saying that can be arrested before time, or if they cannot speak for themselves, the person at the health facility can understand the background, right?
Yeah, actually, the situation in West Pokot is really pathetic. I'm saying that because you find, number one, the infrastructures, there are no roads. Health facilities are too far. You find mothers walk a very long distance to get a health facility where somebody can follow them up. Then I would wish maybe community health workers in such counties like Turkana, West Pokot, and all those places, that they have many of them, so that they can walk, as he's talking about, walk them to the, they identify those ones who are really needy, so that they can go to the hospital and get attended. In that place is where you find a lot of complications, like vesico-vaginal fistulas. There are so many.
Yeah.
You find ruptured uterus. By the time they reach the hospital, is very late. So you find mothers either lose life or they lose their babies. So a lot need to be identified. That's a place where we have around 598 population. Yeah, you find like the number of health facilities. We need to have mobile clinics which can walk to those places where the mother cannot be able to walk, so that the mobile clinic will take care of those bad roads and all that, so that these mothers can get attended in the mobile clinics. Then it comes also the issue of serving and the issue of security. You find in such places, no one wants to work there because it's a bit insecure.
Yes.
So what can the government do to bring some security of those health workers? Even the community health workers need security as such, because the community is a bit hostile. So we have those complications in those areas. We have 101 health facilities in that place, but you find the health workers are not there, or these are a lot of problems.
So there is a gap between the need and, of course, how it is being met. And, of course, this is one of the things that fuels the deaths that we are talking about. So, as you mentioned, they say if the mountain will not come to Muhammad, Muhammad will go to the mountain. So, in this case, as much as the government even slashed the fees for maternity care, there's some who still will not go to hospital. Apart from the distance, it will also because of other reasons. For example, taboos and myths are part and parcel of this. And I'm sure you've had many stories depending on which part of the region of a country we are talking about. Give us some of those instances and how much it's an impediment to taking up maternal health care.
Well, thank you, Gladys. You realize that in some of the remote settings of the nations, people still cling to their culture and beliefs, taboos. And some of these taboos and cultures are very retrogressive. They prevent mothers from accessing safe health care in the facilities. And some of them believe that a mother must give birth at home. That is when you are a strong woman. And in the process, when obstructed labor occurs, based on the infrastructure and the distance to the facilities, as she's explaining, it becomes a great challenge for the health of this mother to be rescued. So most of the maternal deaths occur because of the taboos. You realize that the women in most of the remote areas of Kenya, like West Pokot, you realize that they cling to their cultures, and the woman voice is controlled by the man, and therefore they depend on the assent of the man for them to seek care. And you realize in such places, investing in healthcare delivery at the community level is still very low. Because the community should look at the infrastructure and say, now, because of the devolved systems of governance, let us provide maternal health shelters, where the mothers who are identified to be having risks or having challenges or whichever way, they can be advised to move to the nearest facilities using those shelters. These are not there in place currently.
Okay.
But these are some of the things that are likely to be recommended or the county should pick up and see. If you look at the case of Kilifi County, they have provided in Malindi very good maternal shelters that really have saved lives. So these are some of the things we are saying, taboos and cultures of the communities in terms related to gender really need to be addressed so that people can balance and look at the human life as the first point of priority in terms of trying to be comfortable with some of the retrogressive behaviors or cultures that affect the life of the child and the mother.
All right, we are finally joined by Jane Wanyama. She's the CEO of Aga Khan Hospital in Kisumu. Jane started her career as a diploma-level nurse midwife, so she's in good company. And she's now a holder of an executive master's in business management and a BA in maternal and neonatal nursing degree. Thank you for making time. Now, you just got us at the point where we're talking about how taboos and myths and cultures are normally an impediment to getting the right maternal care, which is imperative in ensuring that we zero rate the deaths we're seeing in maternal, neonatal and child health. From your perspective, looking at it from the western side of the country, how much is this taboos and myths at play in impeding the progress?
So for my thinking, it actually does impact quite a lot, and to be able to mitigate some of these issues, it requires that the healthcare providers or those that are policymakers actually get up to the grassroots. And that's why the role of community health workers or community health volunteers comes in as a very important role, because they completely understand what exactly happens in the households. So they can be able to identify exactly what are those taboos and how then can we be able to mitigate them. And usually, because they are part and parcel of that community, then they would be able to be trusted better when they come in with a new version of looking at things, other than having just to leave it to anybody coming in just as a stranger. And I think this for this reason that when we look at it as a nation, we should be able to see how best we can strengthen the community health strategy in being able to improve maternal and child health indicators.
Okay, now Eunice, we could be talking about the far-flung areas, but right here in Nairobi, where we know that there's no fees attached to maternity care, and yet people shy away from coming to hospital. What are the reasons that you hear why they would rather have the children at home and not in the confines of a hospital?
Sometimes we talk about knowledge gap, because when a mother chooses to deliver at home, she's not anticipating any complication, or rather she is shying away from thinking that she can get a complication following delivery. So it's a very sad thing, because once a mother decides to deliver at home, there must be some either taboo. Even in Nairobi, we have ladies who deliver mothers in their own village, in those slums. There are still women who are giving birth in the slums. But we need really to do a survey and find out more, because you find there are many health facilities in this place. We have free maternity under NHIF. We have what we call Mama Linda program, which is taking care of mothers who cannot be able to pay the NHIF. So you find they register in their healthcare facilities, which is nearer them, and then they can choose where to deliver. But if you find their mothers still who doesn't want to deliver, we really need to interrogate that more. And then we also need to use now the community health strategy to find out more, because health workers, doctor, nurses are not going to go to the village. We'll just work around the health facilities. And then another thing I want to mention is it is important to utilize the health facility which is near you. And in this case, we'll need maybe legislation or something, so that mothers do not clog a lot in one place. Like we have Pneumonia Maternity Hospital in Nairobi, where there are so many mothers who are coming from all over. All over. There's something good about Pneumonia then, irrespective of the fact that
we
talked so badly about it. Then why should you have so many mothers coming? Okay. Why are they not utilizing the health facilities in their place? And maybe some have smooth delivery and all that. So we really need to strengthen that utilization, where a mother can go to the clinic, and these clinics are free. And that's why I congratulate this Nurses Week, Mrs. Uhuru Kenyatta, because she's really passionate about, taking care of those mothers who cannot safe deliver and all that. Then we talk about the referral systems. Then if there's a complication which has happened, that is also there's a gap. Because we find all of us are taking patients to Kenyatta in case.
Yeah. Okay, which brings a very good point, because health in itself is a devolved function. So really, all these mothers do not have to come to Nairobi to get the specialized care or the big hospitals around them. As she's saying, there are those health facilities near them. What are some of the gaps in the communities that are impeding women from going to those facilities and would prefer going to the bigger hospitals or staying at home?
Thank you, Gladys. I think it is just been documented over the years, globally and even nationally, that various factors affect access to health services, especially delivery. Some of these factors that affect women from going to deliver in the facility is lack of knowledge, inadequate knowledge, the way she's saying. This is because they don't have access to capacity building where they are educated on the risks of delivery at home. Two, the planning. If a woman conceives and this woman does not know that she needs to plan based on the distance to the facility and the requirements that she is obligated to provide. Because we are talking of the resource allocation, investment in maternal health services at the facility. But when you go there, even during this dispensation of UHC, you find that those services are still not accessible because those resources are talked outside there on paper. But the funding may not be at the facility to improve the environment. So the facility environment contributes to the negative attitude of a mother to access the services. Because maybe the previous experience, she almost lost her life or she lost a child because of inadequate care. And you tell this mother, please, can you go back? And she has a trusted TBA, traditional birth attendants, next door. even if a community health worker goes several times to talk to this woman, her past experience will continuously signal that there is danger there in the facility.
And I like what he has said, because just the other day on the news, we had that case in Machakos where the lady literally delivered on the floor. And it's unfortunate because nurses were watching her go through the pain of labor and did not help her. Exactly. In such an instant, you would not be surprised if she never went back to hospital, precisely, right,
precisely.
Jane?
Yes, I agree. I think what we really need to look at is what can create demand for these services, especially in the institutions that are already existing. So like as he rightly puts it, one of the things that is really lacking may be the equipment itself. But besides the equipment, so I'm coming to this hospital to give birth, do they have the equipment to see me safely through this delivery? And in most of these institutions that we have, then we should be able to support a continuum of care, starting from a normal delivery to a seamless transition to a cesarean section. And if that does not happen, we know that some of the complications that arise actually arise because of the delays. Do we have the means of transport to take them to a facility that would be able to, for example, and I'm talking of ambulance in this case, to make sure that they can actually safely deliver this baby? When this woman is in labor, somebody should be monitoring that mom. So do we have the equipment that is required to monitor the condition of this baby, the condition of this mother? Because we have maternal complications and fetal complications. And now remember, we're really talking of a situation where people are coming from a place where you are likely to be blamed depending on the outcome. So if I'm going to come to a facility and still end up getting blamed, then really it doesn't help. So we really need to make sure that the facilities are equipped. We need to ensure that those facilities, the health workers that are working there, actually have the know-how of being able to manage. And I really appreciate those institutions that have gone out of their way to make sure that they are ensuring the basic care is provided, the maternal care is provided, even the comprehensive emergency obstetric care is also provided in some of these facilities, that we can ensure there's a smooth transition of that service moving forward. We need male involvement, the gender involvement.
And that's why we have a man on the panel.
Yes. If you look at most of the facilities that we have today, really, the men just feel uncomfortable even coming into it. And we shouldn't be bringing them in at the point of delivery. This means that really from the point of antenatal care, the man should feel comfortable to be part and parcel of this process of care. And the facilities that we are going to be building should actually be facilities that can allow a man or the person, the male factor responsible for this pregnancy, is able to feel comfortable to journey with this woman through the process of pregnancy and childbirth. And enhancing these skills of the nurses and all the workers that are concerned about that is important. And it's one thing to have equipment, it's another thing to have functional equipment. Right? So I see that there are many things that would impact the outcome or the need for these women to think they should actually get to this hospital. Are we providing a seamless transition? Are we providing continuum of care through pregnancy to childbirth and ensuring that indeed we are going to get the right output, which is a normal mom and a normal baby?
Now, our conversation again, maternal, neonatal and child health, and this is prudent because Kenya has been one that has been flagged with a very high number of deaths in as far as those three are concerned. And just looking at some of the numbers that we have on the same, when we think about neonatal deaths, in the numbers coming from the Kenya KDHRC says 1999 to 2003, 33 out of 1,000 births was the number given, 33 deaths out of every 1,000 live births. And that number seems to be going down towards 2010 to 2014, where there are only 22. So there is good news in as far as that is concerned. When it comes to infants, and when you talk about infants, we're talking about the child before their first birthday, right? And this has also looked good through the years. Between 1999 to 2003, the number was 77 deaths out of 1,000 live births. And in 2014, that number was down to 39 out of every 1,000 live births. So we are making progress.
Sure.
But as you have said, there are many gaps in the system. And one of the questions I'd like to pose to you, Eunice, as a midwife, When a mother is pregnant, the antenatal is very important because apart from her own health, it also arrests other issues that could be a risk factor with the child or the pregnancy itself. How many of these women actually embrace antenatal care?
Let me say, it's a very little percent, as you said earlier, the ones who are maybe ignorance, or because antenatal care is very, very crucial in this mother, because the ANC is when you're supposed to take the profile, the HB, the, you know, the rhesus factor. You can have a mother with the negative rhesus factor incompatibility, so you find she's supposed to be given an injection before around 32 weeks to protect herself and the baby.
Yes.
And then in this case, this mother is supposed to see a doctor in the middle. And that's why the mother with such complication or such an issue can be taken an ultrasound scan to identify at this stage, is a baby well, is a mother well. And that's why now you need, as she said, a very good referral system and very clear information. The problem I've seen, that the gap I want to talk about now is about the information the mother gets. Do we give them the right information from the antenatal clinic? Do they really understand? And that's why it's important to have really consistent in every point. If it's the first antenatal clinic, you take those profile, she's given a nutritional, you know, a nutritional counseling, she's given some you know, physiotherapy or something like exercising. It's very, very important. But look at the numbers who come to our clinic. The numbers are too high. How will I stay with this mother explaining all that? Because we have, these days we have individualized care, because we cannot collectively, we can basically talk about these things collectively, but that individual care is very, very crucial because they have different needs. That's why we need to have some time, and you need to have the increase the numbers of midwives, nurses in the health facilities, so that the big numbers who are coming, that I can have enough time to tell this mother this is what is expected, you know, to take this lady nicely so that she can understand. Because 1 minute just examination is not enough. And that's why we don't give, you know, quality education to this mother. And that's why some complications just come because they did not get the right information.
Now, we earlier talked about the importance of actually empowering the community health worker, because if that information was given to them, they would be able to dispense it to that woman back at home. Why it is important for her to leave her comfort zone and go seek help in a hospital. So the question is, if you have somebody who is adamant they will not go to hospital, are there facilities or infrastructure set to bring that care to them to ensure that we save a life?
Thank you. Thank you very much, Gladys. I think it is a very good discussion looking at the behavioral systems that drive health-seeking behavior. When we have this kind of a scenario, we may not say that this mother must be served at home, because there are services that can be provided at the household level. There are services that must be provided at the facility level. And the reason why community health workers are handy in this is because they look at their maternal and child health booklets. The community health workers, when they do household visitation, and when they are trained on maternal, newborn, and child health care, that is a different level of training. We have the general training, and we have the technical training, where now a community health worker is trained on identifying the danger signs in a child. a newborn, the danger sign on a mother before delivery and post-delivery. Now, when they are engaged in working with a mother through the ANC profile, they visit this woman at the household level. Look at the recommendations or the notes of from the health facility, the date of return for review, any recommendations on the diet. Sometimes they are provided there. The person who will identify, especially for such mothers, is the community health worker. Then they walk them through the health education on the need to take up these facilities or these recommendations. Now, where we have behavioral systems that are negative to provide the health to the community, we provide, or it is recommended that the community health worker link with the facility and come to the household with a qualified staff, especially the nurse, maternity, the nurse in the
Health facility.
in the health facility. So when they come at the household level, they will improve in terms of providing more increased knowledge to this woman. And many times we have seen them changing their behavior and adopting the right practices.
So it's sort of like recruiting them and ensuring them along the way.
And in a way, community health workers, where they are supported, they have done wonderful in terms of identifying a model health workers, I mean a model mothers, the mothers who are role models. They have walked this journey and delivered safely. When they were having negative behavior before, they have been taken through education, behavior change, and they have started seeing the benefits of seeking health services promptly through birth planning, through continuous engagement on ANC visits, delivery safe in the hands of skilled providers in the health facility. And these mothers, in some communities, community health workers have grouped them as role models. And they are coming up with support groups to the mothers who are difficult like that. And it is their role now to go to the household and talk to these mothers in their own setting. Because you remember, the mother who is living with you in the same environment understands you better than when you bring a nurse or a community health extension worker from outside. They are outsiders. They don't know your bedroom.
Very true.
So that is how these mothers are supported. But the critical point is that, are we having adequate support to the community health workers to undertake these services? That is where we are.
A good question. Jane, I can see you nodding, and even as you prepare to add on to what he has said, the numbers in some of the places, West Pokot, we had earlier mentioned, grim numbers in as far as maternal, infant and children deaths are concerned, and also Homa Bay County, among others. What is it about some of these counties that seems to be pushing up the numbers?
So other than what we've exactly talked about earlier in terms of really not a strengthened community health strategy, I think, and that's why I was nodding my head when you mentioned the role leaders, we need to see how best to create demand for these services. And one of the things that needs to happen is that we need to look at it that it's beyond the healthcare workers. Seeking maternal and child health services should actually go beyond the healthcare population, the staffs. I'm looking at, we need to look at even the opinion leaders, the political leaders, the MCAs. They should be talking maternal and child health. These numbers should actually be being discussed in those forums that they need to be discussed, and people can be able to understand that really this is the impact and this is how it can definitely make a difference. If we look at Kisii, for example, where we actually had such numbers, I mean, you talked Homa Bay, but I'll talk Kisii, where we've actually had a project happening in the place. One of the issues was access. Just access to the facility was a big issue. When you look at the sustainability of the community health workers and being able to motivate them to continue doing this work, or even having tools that they can be able to make sure that they are monitoring and giving in data that can be able to help make informed decisions on which areas should we actually target to be able to improve the maternal and child health indicators. Without all that, then really we would not be able to get there. So for me, I see it as multifactorial, many things, and really when it comes to maternal and child health issues, it's not just about the woman, it's not just about the partner, it's about us as a government, that we should all go down there and see how best can we be able to improve this. It's about Ministry of Agriculture, it's about the Ministry of Roads, because even if we did all this and the roads are impassable, how will that woman get to the maternity facility? If we did all this and there's no food, she will not be healthy. She'll get to the hospital fine, but she will be anemic. So it is an agenda that needs to be looked at. Maternal and child health indicators and neonatal indicators really are not a business of the Ministry of Health. It is really should be a global thing. It's for all of us to come together, pull together and see how best and what is our role in as far as being able to help improve these indicators.
Now, Eunice, around 70% of neonatal or child deaths are due to conditions that could be prevented or treated with access to simple, affordable interventions. So my question here is, immunization is critical. Yeah. Especially for that young child and even before they turn 5. They say when they turn 5, at least they're out of the danger zone. But what is the uptake? Because some of the counties are saying the uptake is very low in terms of immunization. And why is it still an issue, yet some of these services, if not all, especially in government hospitals, are for free?
Oh, let me say, she has really well talked about the accessibility. These things, the vaccines, vaccination are free. But I want to tell you that there's still a gap. Even those who come to the healthcare facility for the antenatal profile, I am telling you, you can look at the booklet and find the child has missed 1, 2, 3. And that's why I would, in my view, I would recommend something we call a mother class. A mother class is where you're going to group maybe a group of mothers together and teach them the importance of immunizations. What is the danger signs? What are the issues around there? Yes, in the health facility. If there's no health facility, let's give, I said we give a mobile clinic where maybe you can reach them where they are. Yeah? So if they understand the importance of that booklet they are holding, because it carries a lot of information, but you find most of them don't really understand. That's why it's important to give very crucial information at the clinic. When they come for the first time. Why is it this important? Why is the next one important? Why is this, what is the sign you're going to see your baby is not having? Why is this not growing? Why is the weight not? And that needs a quality time. If you want to improve the quality of healthcare, as we approach universal health coverage, then we need to improve some of these things. And that's why we see by accomplishing universal health coverage, then you need to bring nurses on board who are dealing with these mothers directly, who are handling these mothers directly, so that they can have a say at the policy making. So that because they understand what is this these mothers have and what is this quality, what is it that we are lacking, we'll have our views in that. But many times policies are made, like in our country, the national government makes policies, but who does the follow-up? Who is that who does the monitoring and evaluation? Yeah? So that monitoring is very, very crucial, so that people need to understand what is it And then where is a gap? Where can we identify? It's not just making policies and that's all.
Okay, now when it comes to pneumonia, diarrhea, they're still listed as some of the #1 killers of our children under 5 in this day and age. And as she is saying, the mothers need to understand the importance of each and every vaccination process and why it is important to keep your child a certain way. When it comes to the community health workers, they're the ones who see the struggles within the communities in as far as why they don't come to hospital, why they do not follow each and every one of them. Some of the reasons?
Well, as she's saying about the gaps, Eunice talking about the gaps at the facility, I may talk about the gaps at the community. And the gaps at the community is related to inadequate skilled workforce, meaning community health workers statistically, as we talk today, the government says there are over 86,000 in Kenya recruited to provide healthcare, integrated healthcare services at the community level.
But we're not filling them.
We are not filling them because they are not supported. They are not supported because they are not trained. They are not trained because they are not empowered with tools of trade. They want to go to the household. Where are the reporting tools? You find a community health worker is struggling with the paper, and yet we have a very structured reporting tool that can capture the data in the household and empower them as they talk. They reflect on what are some of the key indicators. For instance, if a community health worker goes to the household and lists that today I want to look at the area of maternal, newborn and child health. It's a big area in terms of looking at the mother before pregnancy, during pregnancy, post-pregnancy. How do I talk about all this? A woman can take, or a community health worker can take 2 hours in a household to discuss about this topic. But sometimes they don't have support in terms of preparing. Remember, they are trained and given notes on the exercise books. But where is the structured way of reference? Today, as I talk to you, in AMREF, we have come up with a platform, mobile platform, where community health workers are trained and all the key messages are uploaded on their simple mobile phones. So when they go to the household, he is able to make a reference. And I want to talk about the benefits of antenatal care, the benefits of immunization. He is able to prepare adequately and go to the household well prepared. And when you are prepared, even as a teacher, you'll be able to deliver to your students. But when you go to the classroom and you're a teacher and you don't have lesson notes, you are not prepared, you will talk stories. And then the people who have wisdom, the mothers who are who are enlightened, because today in this generation, don't think people are ignorant. They have an expectation when you visit them. And so most of the time, these mothers, they expect a skilled service provision at the household level. And when they get it, you find they have the desire to work with the community health workers. Look at the areas of appointments. They call the community health workers themselves, or the community workers call them and say, oh, you know, today is my date of going back to the clinic. Oh, you are going? Yes, I'm going. Can you accompany me? Some of the community health workers accompany them. But what do they get in some of our facilities? Some of the nurses that receive them do not recognize referral notes they are given by community health workers. And that brings another level of a gap. Because recognition of community health workers' services need to be linked properly from the household to the health facility. So that when a community health worker provide referral with a referral note written by it is a government document, written MOH 100. Clearly I'm referring this lady because of these complications or these complaints. Maybe she has identified the danger signs of complicated malaria. And you say, now, this one, I cannot support you here, though I'm trained in management of uncomplicated malaria at the household level, but this one, please go to the health facility immediately. This is a pregnant mother, remember, identified with fever, chills, and very clear signs that sometimes maybe there is convulsions, history of convulsions at the household, and you are pregnant. You must be referred promptly. And look, the clinician may discard that referral note to start investigation the way they are trained, which is okay. But if there is harmony, the clinician should recognize, hey, you have come through the community health worker, yes. Here's the note. Oh,
then
this
let's
is very
move
good.
on from there.
Then he gives recognition. One, there's building of confidence on the work this community health worker has done at home.
All right, now, ladies and gents, I need to finish this conversation, but before I do, Jane, you're from the Aga Khan Hospital. Some will hear Aga Khan and say, that's a hospital for the rich. So what are you saying? So what are private sector doing to empower the community health worker? Because clearly we have seen the role, the important role they play, and ensuring that they walk side by side with Kenyans who believe healthcare is beyond them. In 30 seconds, if you may.
So Gladys, for me, it's partnership. Like I'd mentioned earlier, it's not a one-man show. We need to embrace each other's strength and be able to see how best we can make this get to happen. If I reference just Aga Khan Hospital Kisumu today, we are actually an implementing partner in an access project that we are implementing in Kisii, Borabu Bomachoge sub-county. And we have had to work with the Kisii County to see how best we can improve maternal and neonatal and child health indicators, working with the Kisii County itself and the Ministry of Health in Kisii County. This has taken us to the grassroots. We've seen ourselves having to get donor funding that has been able to support the community health workers. And as I speak today, we are looking at how can we even engage them in income generating activities so that when we move out, this program does not fail and we lose out from the benefit that we've been able to see this happen. Knowledge and skills that has been imparted on these nurses and the doctors that are working in these facilities, it's something that they will not lose. But there's need for partnership and sustainability planning so that even when we move out of this, they'll be able to continue renewing their knowledge and skill to be able to take care of these patients. I had earlier mentioned about the facilities and even the equipments. It's one thing to have the equipments, it's one thing to have the facility, but somebody must take care of this. 3 years down the road, it will be run down if nobody takes care of it. So the 100% responsibility still goes to the Ministry of Health. But for us, we come in as partners to see how best can we work together to make sure that we have sustained, we've been able to impact on the outcomes, health outcomes in these facilities. And we are hoping that what has already been put in place really is going to be a story to tell, that we can be able to attract more donors to be able to move to any other place in this country to be able to improve maternal and child health indicators. So yes, there's a role for Aga Khan Hospital Kisumu, and the mother, regardless of whether she comes to Aga Khan, whether she comes to the county hospital, she is a woman and we need to take care of that health. It is not a statistic. It's a woman and it's a baby and it's an infant. They need to come out alive.
Okay, now Eunice, even as we are closing, you're a midwife, you walk this talk every single day of your life. What would be your clarion call to stakeholders to ensure that we zero rate the deaths in as far as maternal, neonatal and child deaths?
Well, thank you. For me, I would really urge the government to add the numbers. We're really having few numbers. When we say Aga Khan, MP Shah, Ward, these private hospitals, those women there cannot afford those private hospitals. Even if the services are given free, I don't think the where the private hospitals beat the public hospitals, there's a very, can we say that we can compete? Which hospital is the best? Like for you, have you ever been in a public hospital?
Yes.
Maybe not. So
Yes.
for the lawmakers, it is important for them to visit. Even you pose as a patient, you can see for yourself. Even the media, you can also go as a patient, so that you show solidarity to us who work there, because we work under strenuous working conditions.
So we need
because
to
the numbers and then we find, even if we work that much, you find no promotions, no incentives. We find we just stagnate there like God knows when.
So nurses need to be taken care of.
Oh, yes.
Also, even as we talk about
Yes.
community health work as well, I need to end this conversation at this point, but definitely a very vital conversation that needs to keep going. Eunice Ngare, midwife and an official at the Kenya National Union of Nurses, George Oele, AMREF Community Health Strategy Technical Advisor, Community Health Workers is his word every single day, and Jane Wanyama, CEO, Aga Khan, Kisumu. Thank you for making time, and of course, as they have said, it's imperative that the right instruments are put in place in enabling a thriving child, maternal and neonatal health strategy that will ensure that we zero rate the deaths. We have been saying we're doing well this far, but a lot more needs to be done. At this point, we take a short break on NTV Today. When we return, that conversation on Huduma number registration, the naysayers will be with us in studio to enlighten us on why they stand against that registration. Stay with us.